Oh, okay, let's try it a third time. We now have sound. We'll do this one more time. Good morning, everyone.
We are.
Right. This is House Human Services Committee, and we are taking up S-36, an act relating to the Medicaid payment model for residential substance use disorder treatment services. And as folks have probably picked up on, that's not really the part of the bill that's causing a lot of people to pay attention to this bill. It's really the public inebriate section, which is section 4, the last couple of sentences. So we are going to be hearing today from the Executive Director of the Northeast Kingdom Human Services. And welcome to the State House, Kelsey. Happy to have you here. That's the hot seat right there. And we'll do a quick round of introductions so that because I think this is your first time here this year at least.
Yes.
Teresa Wood from Waterbury, and I also serve Bolton, Buellscore, and Huntington.
I am Ray Garofano. I live in Essex and I also represent Essex Junction.
Hi, Jubilee McGill, Bridport, Middlebury, Haven, and Woodbridge.
And I'm Rep. Esme Cole of Hartford.
My name is Zon Eustis. I live in Guilford and also represent Vernon.
Good morning, Todd Nielsen, I represent Brandon Farson.
Doug Bishop, Chester is Chittenden 20 District.
Brenda Steady, East Milton, Westford.
Good morning, I'm Dan Noyes. I represent Wolcott, Hyde Park, Johnson, and Belvedere.
Okay, and we'll go around the outside.
I'm Chad DJ with Recovery Counseling.
I'm Faust, Public Partners of Vermont.
That's not what you do.
South Recruit Consulting. I'm Amy Johnson, Vermont Care Partners.
Lori.
Okay, so Lori Morse, community assistant.
That's because I was just telling an individual that's not what she did.
I should say why I'm here.
Yeah. No, who you're with. All right, doesn't matter. It's all good. We know who you are. Yeah. Okay. So welcome, Kelsey. Thank you for being here. And as you know, we are taking up S-36, and there really wasn't any testimony in the Senate about sort of that last section about the public inebriate program. I don't know, you probably know the background, but this is a part has been sort of continued for a number of years. I'm not exactly sure how long, but has been continued for a while. And the bill seeks to remove that section mostly around sections 10 and 11 in the underlying bill. And we understand there's some conversations happening with the Department of Health and Department of Mental Health around how to shore up our public inebriate services in the community. So thank you so much for being here. We appreciate that.
Yeah. Well, thanks for having me. And again, my name is Kelsey Stavseth. I'm the Executive Director at Northeast Kingdom Human Services, which covers the 3 counties of the Northeast Kingdom. And I'm also the co-president of Vermont Care Partners. And also just want to let, we do mental health, substance use, all that, but actually we're a large DS population. About 70% of what we do is DS. So that always shocks people in our area and saying, what are you doing? It's like, well, this is a big part of what we're doing. So
Didn't shock me.
share that. Yeah. Well, of course.
No, I was saying that proudly. I'm like,
Oh, I know. Yeah. Of course.
And Lori, do we have this on? Is it coming on there?
Yeah, but we
Okay, thank you.
So I know the big piece is the repeal, and so I want to speak to that. But before, I kind of want to take the committee through the intentionality of some of the work we're done, and I think the underlying principles, and then talk about the reality, and then talk about the potential impact of the change. So one thing I have to say is that the state has worked really closely to saying what is best practice. I really feel like they're bought into that. When you go and read a lot of the SAMHSA documents, you're like, well, I get what the state's doing. They're reading this, they're trying to implement it. They work really closely with the designated and specialized service agencies to really plan out and saying this is what best practice look like and this is what the vision should be. And I would like to say I think we can all get around to like the theory and the practice and saying this, but how do we do it? And oftentimes you've heard a lot of testimony about like implementing, actualizing the plan requires investment over, a medium period of time to see if it's effective and then good data collection to prove your outcomes. So I just kind of want to like saying there's been a lot of talk of saying we have our care beds, which are really mentally health focused. We've got PIT beds. And a lot of what we've been talking about lately is how do we do co-occurring work and saying, can we do that together? We've had conversations and there are bills and even our provider agreement saying like we should combine the PIT beds and the co-occurring beds to do that together, which sure, in theory can make sense. I do think there's some technical issues that can come with that, which we've been talking about as a network. But, I just, as you look at the crisis continuum and the best practices that SAMHSA has put out, it's got these 11 best practices. And just saying like the biggest one when we talk about community-based care is that anyone who can be served in the community should be, and especially for substance use. So when you're getting connected and you can get your foot in the door like a PIT bed, saying if you're using substances, saying being connected with a provider that can provide medium to long-term care is going to be the best way to do that. And so getting a foot in the door is key to substance use. And so that's a really important piece of having these residential alternatives that can connect you to other supports in your community. And one thing that I do want to emphasize is saying like, it's really important, and again, appreciate the state's thinking around this is saying like, it should be a continuum. It's hard when you just say, let's just have a PIT bed. If that's not embedded in other thinking and other adequately funded services, it's less effective. And so there has to be a lot of thought of saying like, how do you get someone when they're acute or when they're inebriated? Okay, let's come in and saying like, is this a pattern? Is this a problem? Do we have people who are trained that can connect with them and saying like, there are other opportunities? And oftentimes what we see is saying, if we can have community-based options where people can stay with their families, where they can stay working, or they can stay close to their schools, it's far more effective than sending them away. And that's saying we do need inpatient treatment. Those do work. But when people come back or when people have the option for community-based, it's about connecting them and keeping them in the community, which is really important to them personally.
So Kelsey, when I look down through these, this best practice list, honestly, you could put any title of services in front of you. So you've got crisis services, but you could say developmental services, you could say substance use services, you could say homelessness services. I mean, all of those, 11 tenets of good services, should reflected, broadly in human services. And so it actually helps me to think about somebody who is in potential need of a short-term place because of, how they arrive in the community and being a danger to themselves or others. And I'm going to play Representative Donahue because she's not here. And the sort of the 24-hour on-call emergency services that the designated agencies have as one of their core services. I think about, I think Representative Donahue would say, is that really serving a different purpose? So I know that she has some concerns about whether it's the right fit or the right match to be thinking about that. I'm just, and if you're going to go into that a little bit more, then, I'll sort of leave that to the side and she might be joining us. But I guess I just wanted to make sure that we addressed it today, at least so that you have it in the back of your mind about whether this is a good match or whether it isn't a good match. Also recognizing the economic realities of running two 24/7 programs. Very difficult to staff, and especially when you have people maybe not being fully utilized because you don't need to utilize them all the time. So, okay.
And so she's saying that Rep. Donahue would say that combining them doesn't make sense, or,
Yeah.
okay.
Yeah. she has some concerns about it.
Yeah.
I don't think that she'd like say, you know, no way. I think that she just has some concerns in wanting to assure that the mental health needs of individuals don't, get put in the background somehow. That they're still, front and center, and that there's not a lack of access to somebody who's in a mental health crisis because the staff are being torn to a public inebriate situation. Honestly, both individuals need help. But, not, I guess, not wanting to dilute the access for people who might be in a mental health crisis.
Yeah, that totally makes sense. And I'll speak to that a little bit. I want to talk about the theory and then talk about what we've done in Northeast Kingdom Human Services to connect these things and saying like, what does that look like on the ground when we do it? So
Mhm.
I will get to that.
Okay.
One thing I do really want to note here too is saying like, I think the state is really innovative. I think the legislature's been really supportive, especially in NHS. We'll talk about the front porch later, which is our urgent care model. But that when implementing new programming, when you're trying to do some infidelity, it really takes at least 2 years to get there. So when you're saying like, how's it going over 6 months? You're like, okay, I think, it's about, and one thing we've really found is like the behavior change of the community, like the difference between call 911 and 988 is just like that second nature. There's an emergency, call 911. There's an emergency, call 911. It's like, oh, this is a mental health emergency. I heard about 988. I guess I'll try them and see how that goes. Like that is something that takes time to change. And we'll talk about 988 a little bit and saying like, that's been going for 3 years now and saying, we're going to see the impact of, a press on saying, are people aware of this and can we utilize this differently, which is all about saying right place, right time and alleviating pressure on other services that don't feel equipped or appropriate. So I always like this one. There's different variations of the crisis continuum, but saying like, look, if we're really talking about co-occurring and we're talking about crisis, we need to have 988. So can you call somebody who's well-trained and saying, look, if we can resolve the issues on the phone, that's great. If not, we could send somebody out to you. So 988 is really not just for the person in crisis. It's anybody who is circling them, including law enforcement or other professionals. We can send somebody to you. So that's mobile crisis. The way we look at that is we do a lot of co-occurring and we're open to that. Then we've got the 23-hour or considered urgent care, behavioral health or mental health or co-occurring urgent care. There's different names for that. And then there's the crisis treatment, which when we look at crisis, what we've got going on, it would be 2 to 10 day stabilization. If you need longer recovery supports, we've got a few in-house, and then sometimes people go out of state and then we'll come back, or we've got inpatient with Brattleboro. But the idea and what we've actually built out is that top section that's blue to circumvent the purple, which is, not necessarily, trained to respond specifically to co-occurring issues and is usually more intensive and more expensive. And so the idea of the crisis continuum at the top is saying, look, these are better supports and they're actually less intensive. They keep people in the community and they're less expensive. And so one thing I will know, this says peer respite, but that the peer workforce is really important to what we're doing. And we found that at Front Porch too, saying having peers who can connect with folks on that level of saying like, I have lived experience with you has been really instrumental in developing therapeutic relationships with folks. And so I just want to note that that's been a really good push for us, but at the state level too. So again, 988 mobile crisis. We've also got another response. So the VSP embedded folks. So we kind of consider that as part of our network of crisis. And we try to work really collaboratively to share information so we can respond appropriately. So
Can I ask you just mentioned the state police. So does that ring true in terms of what's the experience with the sheriffs? Because in a lot of rural parts of the state, it's the sheriffs that will respond because there's no local police force and state police are not.
So we're closely connected with our sheriffs in both Orleans and Caledonia County. And saying, we don't get a ton of response from them. I think it is mostly VSP that's kind of going out. But again, when you're talking very rural, it's like whoever can get there. So our VSP, we have 2. We have the St. John's Ferry Barracks and the Newport Barracks. And so we can respond out of there. But again, as you get rural and go talking Canaan and, it's just a long ways to get there. And so I think whoever's closest in emergency is going to try and get there. And that might be us, but we have a 2-hour window. So, it's hard. And we know that VSP has limited availability too, and it can take an hour and a half for them to get there too. So
Which 2-hour window?
Oh, sorry, mobile crisis in rural areas, we have a 2 hour, that's an outcome saying that if somebody calls and says, hey, we need support, we want to try and get there within 2 hours. That's the kind of like standard that's set. Our average is around 30 minutes actually, so we've done well that way, but we do, knowing we cover 2,000 square miles and from St. Johnsbury to Canaan, it's an hour and 20 minutes and the opposite direction to Hardwick is 40 minutes. And so you're talking like, you got a lot of ground to cover and not great ways to get around in rural areas. So
You have a lot of real estate.
we do.
Yeah.
So I just want to highlight saying, going back to Fidelity and saying like, this has been well thought out and, how 988 came to be too was, it used to be the suicide prevention lifeline. And so NKHS and NCSS picked that up and we still do that. So we do nights and weekends and NCSS does basically Monday through Friday during kind of like regular business.
Not everybody knows the acronyms.
Oh, sorry.
Northwest Counseling is.
Yes, thank you. I know we can't see
Yeah, go on.
here.
I'm just wondering, there's that huge jump in June, that kind of stays. Have you, what?
I know, sorry. I know where you're going. Go on.
Yeah, have you identified, like, what, was there,
I think,
Do you know the
so
reason?
nationally, there's been a lot more awareness about 988. And so a couple things did change. One, we added another call responder because of the volume is needed. And so the way 988 works is if you call in and someone's on the phone and you don't pick up after 45 seconds, it rolls to our backup, which is Headrest in New Hampshire. And if they can't answer, then it rolls to national. So you're always going to get somebody, but this is about our call volume. And we're just saying, hey, look at the
Okay.
data and saying, when we drop below 80%, we have regular meetings with the national folks who have really great data and saying like, we don't, so what are you going to do? Well, one, we got to add more people. And two, we also employ technology, so a unified platform. So if call volume really goes up, you can answer calls from anywhere. So we do have a call center, which is helpful, but you can also work it from home saying, hey, we've got a really high volume and people can just pick that up. And so our ES director or managers can just pick it up from home. So it allowed us to be way more responsive.
So are you saying that Northeast Kingdom and NCSS, they answer all the 988 calls for the whole state?
Yep.
Okay, I didn't know that.
Yep. And so, if we're too busy, it does roll, but
Yeah.
I think we're in the 90s now on average. And so that's really, we want to be able to answer all of our calls. And actually where we're headed is, so 911, right, dispatch, that's actually where the state is trying to go. And HCRS owns the mobile crisis contract for the whole state, but trying to get a platform. How do we dispatch people? So to really mirror the 988 saying, so the first line is going to be 988, but they'll be able to dispatch if you need someone to go out. So that's the theory, is like to model some of that.
Thank you. Rip Cole?
I'm curious if you've heard feedback from the police departments about how this has impacted their intake or their call volume at 911 level.
Yeah. So we work really closely with law enforcement. St. Johnsbury was just added to the public safety enhancement team. And so we're part of that, but it's been really close to VSP, but also St. Johnsbury and Newport PD. And so, we're trying to do co-response as needed and make sure we're getting pinged, but I don't think we haven't talked about seeing the volume decrease. And from my sense of looking over call volume, it doesn't feel like there's been a lot of like decrease in the 911 calls, even though there's been a big uptick. So it's a good question, but I'm not sure if there's enough data to saying like what's changed, or is there a volume? I haven't seen the 911 call volume, I guess. So it might be nice to compare that.
Or even beyond just volume, like the nature of the calls too,
Yeah.
would be interesting to compare.
Yeah. And so, we have a ton of data on this. We're happy to come back and talk about 988. But I just want to talk about kind of where we're headed, which is related to the PIPED. I know that's what we're here to talk about. But this is connected in saying like the planning is really important, saying how do we make PIP work successful. And so this is just text and chat. So we've seen increase in this and just the data. I don't want to get too much into this, but
I know, we could go down a rabbit hole, so keep going, yeah.
saying mobile crisis again to Fidelity, we've been at it for about a year. And so we've seen just a frequent increase in this. And so again, this is about behavior change, making sure people call us. One of the things that we have run into with law enforcement, and we've really been trying to work hard, is saying in first responders, we just met with our local fire department and EMS is saying like, they respond in minutes and we have this big window, and saying it might be more appropriate for us to come, or they're actually looking for us to relieve them if the higher level of care is not needed. But if it's going to be 30 minutes even, or an hour, like they're like, we can't wait, we're just going to go to the hospital. And so like, how do we come up with a better way to respond in a timely way, saying yes, there's always going to be need. Maybe people don't call 911, but if there is an acute emergency and maybe it's not medical in nature, EMS, fire, police are always going to get there quicker just because that's how they're set up, especially in the town areas that have local PD. So that's been a tension we've been trying to figure out, is saying like, how do we do a co-response as we try and think about ourselves as first responders, but also make sure that it's a more appropriate response. So that's one of the tensions here, saying, yes, behavior change. Do people know about this? And can we really trim down on the timing? Because a lot of folks are saying like, we could use you. This is wasting our time. And we're going out to see this person like 10 times a week. But we just bring them to the hospital because we can't wait and we have to get back and be prepared for something else that comes up. So there's still a little bit of timing here, saying like, how can we be more responsive or keep working on the program to saying like, when we're responding to co-occurring work or, mental health crises, that we are responsive and alleviating, fulfilling the purpose of this.
Does that still happen in the, your public inebriate?
Yeah,
Side
that's
of things,
huge.
yeah.
And so kind of lining up this, saying we're having the same trouble, which is basically like the way we're funded, and I'll get into that in a minute, is just saying like, we have to do an on-call model or lose a ton of money if we're going to staff it 24/7, which is what's actually needed, because you don't know when people are going to come in.
Right.
And so the police are like, we can't wait 30 minutes. We're going to the hospital. We're going to the hospital. We're going to the hospital. So, it is saying that's kind of the reality of the situation, of saying like, good idea. The execution's not helpful around the programming, and saying the reality is people are just, they're not going to wait because they've got a lot of calls and they're very busy, and saying we can't wait around for 30 or 40 minutes for someone to arrive at the building.
And so you're,
So
yeah, all right, keep
Yeah.
going, keep going.
So this is kind of like saying, so the front porch, which is our mental health and co-occurring urgent care, and it is important to note that it is co-occurring, and this is different than some of the other urgent care facilities, which were stood up. We're talking about Moochie's, and this got started through some federal delegation, but it's been carried on. So Interlude at in Addison County, Puck in Bennington County, Howard's opening their one in collaboration in Burlington with UVM and Pathways. And then Lamoille County has Epic. They all look slightly different. We built ours really intentionally because we had a lot of support from the state to do some procuring of a building and then really just build this out the way we want it. And so we built this saying like, this is for everybody, including co-occurring. We have done co-occurring. And when you look at the data, I think last month we were almost 70% were co-occurring with substance use, or it's over 50%. We also do DS services here in crisis, and saying, look, like if we're really going to benefit from ES, and going back to what you're saying, Teresa, those best practices that can be applied to everybody. So really saying like, if it's not medically in nature, if it's not really geared towards the specifics of the acute issue, we can have a wide door and then, triage appropriately, and still saying, and so what we've really done here is saying, look, send people here. We work with law enforcement, they'll just drop people off. We're saying, let's bring them here, and we can say, hey, I think this person actually needs medical support. We're really close to the hospital. So there was a lot of intentional work that went into this, citing the location, the planning, and saying, okay, we do co-occurring. That's not the case for all of the crisis beds and PIPs. And so just combining them elsewhere may not make sense for other agencies because they didn't have the ability to like really intentionally build it. But we've done that with the training. And then so you can see here on the bottom that green line with the percentages is the percent of people who went to the ED.
Yeah,
So
which is
we
good.
have been doing, and that's the purpose.
And do you have the same level of data about, I guess I'm asking, was anybody charged or arrested that's, started out as a mental health or substance use emergency?
Yeah, and so we do have like referral sources saying law enforcement and probation and parole. And so we can go, we collect a good amount of data on that.
Okay.
And can come back and talk in depth about that.
So, so you benefited from being able sort of to build something from the ground up, recognizing that you were going to do both at the same time, as opposed to somebody who maybe
Using
it is, has been running a crisis program, mental health crisis program, and is now thinking about how do I integrate public inebriate, which I hate I don't like the way it sounds, but how do they integrate that in? So, I mean, there's obviously benefits from the approach that you were able to take.
Right.
And hopefully there's some sharing of information among the colleagues to help people learn from the experiences that you and others are having with building that from the ground up. That's inclusive of both groups of individuals.
Yeah. Yeah, we definitely share. I mean, that's one of the best parts about Vermont Care Partners. We're always sharing and visiting each other's spots and talking about it monthly at all our different committees and board meetings. And then I just had a note saying, we weren't able to put the March numbers in there, but we did see 101
See that,
people.
yeah.
So saying like, again, going back to the Fidelity model, it's been open less than a year. And so we've really focused on partnerships with all of our local organizations and advertising, saying like, look, just come here. Like, how do you get in? You show up and then we will work with you to figure it out. And then we're super close to the hospital. So we can say, what are we doing? So this is really focused on, so we have peers and clinicians there or clinician available. But this is, when we talk about some of what's in the bill, and I know we're talking specifically about the repeal for PIP, but there's a difference between like clinically managed, like withdrawal and social detox. Those are two different things. So you're gonna need nursing and psych oversight if you're doing that, which can be pretty delicate with people who are withdrawing from alcohol or opiates, and saying like sometimes that is a medical program. So there is a difference there, and saying we're certainly trained to saying like if you're concerned, like let's call an ambulance, because we're not prepared to do the medical work here. That's not our plan. We do have some psychiatric oversight that we can use, but we're not really here to monitor people medically. That is not the purpose of these urgent cares that could be co-occurring.
Do you have data that shows how many people or what percentage of the folks who are identified here, the utilization of hospital services prior to the implementation of Front Porch?
I think we're trying to work towards that. We do have like shared team meetings, and we also with NVRH and working on this with North Country, we have, it's called an OCA. I forget what that's called, but basically a shared services agreement where we can share data and saying, so when people come in, so we're on our way to doing that. We also have patient ping. So when someone's discharged from inpatient or hospital, like we can have that shared data saying, hey, we should follow up with this person. So we do have some data, but I would say it's limited to figure out like, are people going to the hospital afterwards? That's what we'd love to know, is saying like, does the intervention here in connection to other services prevent them from using the higher level services over time? But we don't have that data yet.
Okay,
So definitely where we're headed.
go ahead, Representative Bishop.
Do you have length of stay information?
Yes. Yep. So I do have all this, and I'm happy to come back and do a more detailed kind of presentation on the Front Porch itself. I would be happy to do that. I think I would enjoy that, and we do have a lot of data. Yeah, for sure. But I think what I'm trying to lay out is the continuum that we have been able to build has led to the success.
Mhm.
And so I really want to emphasize that when we get to the part of really specifically talking about the PIP beds,
Mhm.
because without like a really intentional approach to this, like you're just not going to have great outcomes, and it's going to, kind of work against itself. Oops. So, here we go. So, this is just saying total encounter, substance use co-occurring, and then developmental services co-occurring. And so a good number, over half, at least I forget most recently, but they're not clients that are established with KHS. These are people from the community that just support. So that was a big question that we had to say, are we just going to see all the same people that we're already serving in the cases that a majority are not? And so we are currently in the process of renovating the building to have 4 crisis stabilization beds. So right now this is only for the 23-hour urgent care. So we have had people stay that whole time. I think the average length of stay is around 2 hours to kind of get some check-in and then stabilization, but we have had people stay a long time. So we're saying probably end of summer, we should be done with the 4 beds. And so again, those will be co-occurring, and saying like living room model, and saying like we really want to be able to saying, hey, if we can get you in here and you need to stay. And this is about, again, it's not a locked facility, it's volunteer, but you can come, you can go to work, you can do your life and come back. And so it's really about stabilization and then connection to long-term treatment if needed. So again, the intentionality behind that was really informed by the state, and we went and visited a program in New York and reading the SAMHSA best practice guidelines. So we really built it around that. And, for the urgent care, it's been very successful. So talking about the PIP beds. So one thing I really want to note is saying, look, the way we're funded for PIP beds, we get $140,000 a year. And saying, okay, like, how do we staff that appropriately? And I think, you say you want to have Jennifer Stratton in, we've talked about this, but they closed because they staffed it with a person there 24/7. And so they were losing hundreds of thousands of dollars a year because if you're going to have someone there who's available to the police to show up and just say, hey, I have somebody, instead of saying, hey, we'll be there in 30 minutes, like they're just not going to do it. And we've had many conversations. I remember when I was at Howard Center with the Team 2 trainings, it was really illuminating to hear the frustrations of law enforcement saying, like, I get it. It feels dangerous, but this isn't a crime. We can't follow someone who just left a recovery residence who doesn't want to be there and saying, like, that's not our job. We can't just hang out with people who we think are in danger. Like it's not our job. It's not that they don't want to, they just have a lot of work to do. And so the timing is a real issue. And so our PIP bed is really underutilized and saying, like, the data looks bad and saying, like, and really when we talk with our law enforcement, they say, hey, this is a good idea, but first of all, the hospital's up the road and we're just going to drop them off and then go back to doing what we're going to do. And so the reality is saying, look, the way it's funded, it just doesn't make sense. So either we need to eat the cost, and so we're going to subsidize it through other programming, which is not ideal, but maybe if we decide that's the most important thing that we can do. And that's just the reality. So we've just decided to say, hey, we can be on call, but the police have basically stopped calling us because they don't want to wait. And it's not because they don't want to use it, it just doesn't work into their workflow. And so if we're going to staff something and have it be effective, you need to have folks there. I will say, so our care bed and our PIP bed are in the same place. And so we have not done co-occurring yet. And I think probably to Representative Pugh saying, like, we want to be really thoughtful about how that's set up. And again, our care bed in St. Johnsbury is different than the front porch, and it wasn't designed initially for that, and saying, like, could we just switch it, and saying, maybe we're thinking about that internally and saying, like, maybe the state is saying, can you lump these two things in? Maybe. I think we're still really trying to figure out if that's possible, given the setup.
So now I'm a little confused. So in front porch,
Yeah.
would those folks respond if you got a call from law enforcement saying, we have someone, who is inebriated here and we're going to take him to the hospital unless you can come? Or and
Maybe
they
dropped
would,
off at front
yeah, that would they,
Yeah.
can they, or would they drop them at front porch?
They could, but St. J. PD is not going to drop people off in Newport. And I think the front porch is Newport. So this is a geographic issue, saying, like, how far are you going to travel? And St. J. PD is not going to drive an hour to Newport and back. Like, that's the whole point of saying St. J. Police only covers 1 square mile. And so it's a regional transport and timing issue, and saying, sure, they could absolutely go there. But the coordination around that, and then saying, well, who else will do it? Oh, you're going to get an ambulance ride for an hour. So
Right.
Yeah.
So I get that. So in Newport with front porch, is that what happens for people in Newport? And
the police will come right to the front porch and drop
they
people.
come right to the front porch and drop them off.
Yeah,
And is that a blended funding? Do you have PIP funding in Newport as well as you
So the
don't?
front porch, again, I think this is why it's been really successful, was
Yeah.
grant funded through the legislature at the behest of AHS. And one thing that they're trying to do is saying, we are collecting payer data and saying, hey, can you bill directly for this? And saying, like, maybe, but you're going to get into the same thing, which is, when we consider our crisis work, we want to talk about it as a firehouse model. That's how it's going to work best, which is flexible block grant funding. We're moving away from that. So it is really concerning. It'd be like, I always like to use the analogy of the fire department. If you paid the fire department on a per fire, basis, you'd either, people would just go home and it'd take a lot longer for them to get there, or you'd wish for more fires. Like, no one does that. You love the fire department because they are staffed and ready to respond when there's a crisis. They're just going, they're there in minutes. That's like the whole point. Is really well designed, but the funding allows them to saying, hey, this is how many officers we can have. And it's a capacity model, not a fee for service model. And so I understand the financial pressures, but when you head towards fee for service for crisis work, you start to get less quality. And so we will see quality go down. We'll be not staffed 24/7. We'll be less responsive to law enforcement. I think that's what we're seeing with the PIP funding, and saying, some of our saying, like, look, I think we can do this well. Let's find the sweet spot. And, this is a little bit of back of the napkin math here, but it is saying, like, look, there's a sweet spot that's more than what we're currently funded and less than how much it costs to go to the emergency department. And so, this requires, again, intentionality, good data collection, and saying, like, to your point, do people stop going to the ED after this? Because if you go to the PIP and then you go to the ED, like, it's not fulfilling its mandate and its purpose to divert people from this higher level of care that's also more expensive. And so we really are trying to make sure our data reflects like the importance of that and saying like people are going home after this. And so we do have discharge disposition saying where are people discharged to, and as you saw on the data for the front porch, it's very minimal are going to the ED. And
Right.
usually that's right off saying this person's not appropriate. It's not that they stay. So
Right. And so in St. Johnsbury, since, well, the correctional facility there is not exactly. I'm just trying, I'm just trying to figure out, since in St. Johnsbury, you kind of have all three. You've got you got a mental health agency, you've got a hospital, and you have a correctional facility. So, what determines where somebody's going to end up, in that greater St. Johnsbury area?
Yep. I mean, I think kind of going back to saying like what is most convenient and effective, and saying it's going to be a timing issue. Again, law enforcement saying like, the prison is down the road and we're not calling the pit bed and we're going to go there, or this person is so intoxicated, we're worried medically and we're going to bring him to the hospital. I mean, those are really the two options that happen now. It's saying like, how do you determine what's most appropriate? And it's really the hospital or prison.
Mhm.
And I think that's saying that for lack of like, the conceptual model, but from the reality of it is saying that it's underutilized.
And how, you didn't tell us how much it cost for, the front porch.
Yeah, so I would say that, so we started in, well, we've had it as we're building it up. So I would say we're on pace for the fiscal year to be under $1 million. I think it was granted to be 1.6, but our staffing model, and we'll see a little bit of an uptick when we open the 4 beds, saying like maybe we need one other person, but I don't think we'll need the full funding. But you're talking about $1 million.
Roughly $1 million a year.
And so that's for 4 crisis stabilization beds and a 23-hour urgent care facility that's got 4 beds. And we serve adults, children, families.
Mhm.
So
Mhm.
it's meant to be a comprehensive model. But I think that's the tension, right? Is saying like in here, just kind of put out, say, even if you have 2 staff and you're paying $25 an hour with fringe and a little bit of admin, you're talking $700,000 just to have people who are available. And when you're talking about the acute, we don't really want people to be alone. We need to prioritize safety. And so having one person on, you could have one person there to receive them and then on call. So we can get flexible about that, but you're really going to want to have 2 people. And so, minimum, you're really talking just for that. And that doesn't, include anything else that would come with that, with staff and stuff. You're talking $700,000. But if you're effective and really working in partnership, which we're trying to demonstrate with the front porch, you should be able to see the savings saying these people didn't go to the ED, which is the most expensive support in the community.
Go ahead.
So I think there's obviously, as there always, there's a couple of questions involved here, one of which is the best option for the individual. For where they're at. There's also, as you have numbers up there, there's a cost issue. And when you cost out the ER visits, you have it at the full 83.3 visits.
Yeah.
Do you know how many would go to or percentage wise roughly may go to the ER versus being taken to corrections?
I don't. So in St. J, I'm not sure how that data. No, we don't.
Yeah,
we
that's
don't
what I was
watch
just
that.
asking before.
So that's a good
sorry.
question.
Yeah, no,
What I'm
that,
trying to figure out is, we've got a cost there of $1 million, which
Yeah.
is $300,000 more than that, than the other model. But is it something less than that? It's whatever, it's a mix of the ER and the DOC costs.
Yeah. And so, part of the philosophy here too, and this is really about data gathering and a philosophy and saying like, we want to see less usage and saying if people go to prison, they're not connected. It's just a holding thing overnight. So again, going back to substance use best practice, saying if you get a foot in the door with somebody and then connect them to services, like, yes, we are trying to work with DOC, but that is hey, let's hold you overnight. And then you're free to go once you're sober enough to be released. And so, some of the philosophy is saying, look, we really believe that community-based options are the best. They need to be adequately funded. And then you need to have good data saying like, are we using our tax dollars effectively with good outcomes and diverting people from prison and having good long-term outcomes and looking at indicators in our community. And so again, this is a commitment over a medium-term period, which we're talking, 2 to 4 years of saying like, let's study the data and make sure we're doing it really well. So again, as we're trying to demonstrate the efficacy of a program like the front porch, like the data collection is going to be really key to saying like, will this work? Does it make sense? And is it cost effective?
well, even, since you said you're looking at front porch, you're roughly at the same as cost for ER level 3. But, in my estimation, what you're building in the community is a much more comprehensive and more effective for the individual on a long-term basis and for the community. So, even if there isn't any quote unquote savings between the two, you have, I think, better effectiveness with what you're building in Newport. So,
Yeah, agreed.
yeah.
And so, and one of the things that's really key and we really prioritize too is a partnership. And so I got to speak really highly of our partners, saying like we attend meetings with both hospitals on a regular basis, almost weekly. And we have one bigger team meeting monthly. So saying, what are you seeing? What do you need? How do you refer people? What's the appropriateness? And so, I still get sometimes I was meeting with the superintendent. I'm like, so you call my name? He's like, what's my name? I'm like, no way. You do not know what that is. And so again, the education and kind of behavior change of saying like, how could that not even have, we're like putting it out everywhere. I'm saying, all right, I'll send you a bunch of cards here. Please hand these out and put them up. But saying, as we get going, saying people just understanding what this is and then having a good experience is really key. And we want to make sure that it's effective. And so, really to get back to the last question is saying like the way it's built now, there are not regional models to effectively take people, in acute care. And so I think that, Section 4 of the bill is really speaking to saying like, what will happen come July 1st if the bill passes? We're always believe in the community-based supports are the best. But as you saw, just using our example, saying like, basically the PIP-ED is an ineffective program because we can't afford to staff it 24/7 and people aren't going to wait 30 minutes for us to get there. And they're not call on, they're just going to go to the prison or whatever. And so holding people is a good option. If you take away the prison option, what's going to happen? We got the hospital probably is what's going to happen. And so to your point, what's the spread? Well, it's going to be 100%.
The problem is that we don't have any data. I mean, we haven't.
Exactly,
seen data.
yeah.
I don't know what the breakout is between how many people go to the hospital, how many people go to the correctional facility, how many people coming to you. I mean, we know now how many people coming to you in Newport.
Right.
But so we, the department is supposed to be providing some of that data.
Okay.
And, I think that the health department seems engaged. I don't know if that's your perspective, but they seem engaged in wanting to think about PIP beds in a different way. So I don't know. To me, just as me personally, it seems a little premature to just repeal what's in statute right now. Because if there is a better way, what we want to do is build the community system. And I just wonder if we take that pressure off, how much longer will it take to have that community system be more responsive? And it's great what you're doing in Newport, but if we don't have that in Springfield, if we don't have that in Bennington, if we don't have that, in Barry, those are the places where, we need to have it statewide, and so I appreciate you sharing all of this with us because it's, for me, it's new information, probably is for some of the other folks as well. So appreciate it a lot.
And we are actively working with, the Department of Health and AHS and DMH to try and figure this out. We're in our provider agreement negotiations that we do every year. And so the PIP funding has come up, but we just haven't seen any of the funding information. So it's really hard to plan, again, saying like, I think we can do this if it's adequately funded and has, a thoughtful implementation.
Yeah.
So we agree, community supports and services are going to be best, I think, short, medium, long term, and have the best outcomes. But it just needs to be adequately funded and intentionally implemented.
Yeah, I that's an excellent way to sum it up. Folks have any additional questions for this witness? Thank you so much. It's really been very, very helpful and appreciate you coming down from the kingdom this morning.
Yeah, no, happy to be here. Thanks for having me.
That's great. Thank you. Yeah,
That's funny.
thank you so much. Appreciate it. Okay. Welcome, Chad. Step right up. The next contestant. So you're going to speak, I'm presuming, about the part of the bill that seems less controversial.
Okay.
Well, I operate 5 public inebriate beds.
Oh, there you go. Okay, no, I didn't realize that. So you
The whole
can
bill.
do the whole thing. That's great.
Excellent. Thank you, Madam Chair. Thank you, committee members for having me. Do want to give praise and thanks to NKHS and the great work that you're doing with the crisis services. That's very difficult work, and I appreciate what you're doing up there. Thank you. So I testified downstairs on S36, and I wanted to walk you through some of it. I believe we've sent over my testimony for
Yes.
today. But before I start, I should probably introduce myself again. That's probably a good starting point. My name is Chad Vijay. I am the Chief Executive Officer of Recovery House, Inc. I am also the president of the Vermont Substance Use Treatment Collaborative that has about 14 ongoing members, including designated agencies and other preferred providers. In addition to that, I moonlight as a professor with the Vermont State College system over in Castleton. So
I really wanted you to say you moonlighted as a DJ or something.
Great idea. So Recovery House, to give you a little bit of our history and who we are, despite our name, we do not offer recovery residence or recovery housing. We are a substance use treatment provider, and under our purview, we have Serenity House, Grace House, the newly opened McGee House, and we also operate 5 public inebriate beds for Rutland and Addison County. To walk you through a bit of the continuum of care and the houses that we have to offer, we are offering the highest levels of care when it comes to substance use treatment outside of a hospital. At Serenity House, we're licensed for 34 beds. That is the high intensity, medically monitored substance use treatment that is in section 1 of this bill. And there's some very specific language changes that took place to avoid short-term versus long-term language. Our Grace House and McGee House operate at the low intensity, clinically managed levels of care. These are our longer lengths of stay, typically 90 days. There is no medical component to these programs, but they are clinical in nature, where they receive individual counseling, group counseling, and aftercare services, planning for the next step. We've developed these lower levels of care in response to the need for that transition between our highest level of care and outpatient services. And when you look at the engagement rate for folks who leave the highest levels of care, it is pretty low, despite many efforts while they're with us to prepare for engagement with outpatient providers. And many folks need continued 24/7 support, but not at our highest levels of care. They don't often need nursing care for a month at a time. Right? So we're very fortunate, very happy that we were able to bring on the McGee House. At McGee House, we have 16 beds. At Grace House, we have 12 additional beds. So 28 beds in total to fill this need for the state. I know my vision isn't quite a part of this bill, but the vision would include developing that further in different communities of support throughout the state. Our public inebriate program, we've been operating since the public inebriate program started. I too, not fond of the name, but we are working with the state to reimagine these beds as engagement beds. And I'll talk a little bit about that with some case studies that we have.
Can I just add, when you, so you said you operate 5 beds for Access in Rutland and Addison County.
Yes.
And so is that instead of them being at a designated agency, or does the designated agencies in those 2 places have them as well?
No, we are the only.
You're the only ones. Okay. And how is your funding similar to the levels that we just heard about from Northeast Kingdom, or?
Yes.
Okay.
Where we've had our success is that we're co-located with our Grace House.
Yeah.
And so we're staffing 24/7 regardless.
Mm-hmm.
And we're able to monitor our public inebriates at the same time.
So you sort of have a hybrid kind of option in when I'm thinking about the existing, it's not with emergency services or, like a designated agency, but you have available 24/7 staff in another program that you utilize to help staff your public inebriate program.
Yes.
Yeah. It seems like the only way it could possibly work is if that exists already, to be honest.
Financially, that's accurate.
Yeah, okay. All right, thank you.
And speaking about our public inebriate program, so we work very well with Rutland Regional Medical Center and Rutland City Police Department, Rutland Town Police, every police department in the area, Vermont State Police, the Sheriff's Department. We range from Manchester all the way up to Middlebury, over to Virgins, Killington even. Our process has been, let's say, perfected over the last decade or so. But when an individual is picked up by law enforcement, they're brought to us and we do a screening. And that screening indicates where they should be, right? And the majority of the folks that we screen, we are able to offer a safe bed until they are until their blood alcohol level is at a safe limit. The reason why we would send an individual to the hospital is if they were in some sort of mental health crisis or physically there was a medical concern that needed to be attended to. Our reason for sending folks to the correctional facility, Marble Valley, is when folks are combative, aggressive, or refusing our beds, refusing the hospital. That's been in the minority of folks that get screened by us, but it is a percentage. I don't have the number in front of me, but it's been on an individual basis, and we are looking specifically at how the individual is presenting to decide what the best place for care is. When they do go to the correctional facility, when their blood alcohol level has returned to a safe limit, Marble Valley will call us. We'll go into the correctional facility and we'll talk to them about options and try to get them into treatment, whether it's outpatient or with us on the inpatient side of things. So we have wonderful interactions with law enforcement, and geographically, we're probably a bit at an advantage where they don't have to travel too far. We're about a 30-second walk to the police station, a 2-minute drive to the correctional facility, and a 2-minute drive to the hospital. So it's worked out very well for us in this area. A few case studies that I've provided in written testimony demonstrate how we have utilized these public inebriate beds and how we've expanded I don't want to say the capacity, but the rationale behind how we're using these beds. In case study one, we had an individual go to our public inebriate program through law enforcement. They were picked up, brought to us, they were assessed. We offered them a safe bed. From there, while we were talking with them and interacting, we discovered that they were interested in inpatient treatment. We were able to bring them directly to Serenity House. From there, they had undergone about a 2-3 week stay and applied for and was transitioned to our Grace House program, where they stayed for 90 days. And this was a great use of our public inebriate program as it was intended through legislation. Case study B, you'll read that it includes an individual who came to Serenity House first and went through a 2-3 week stay in treatment, and then transitioned to our Grace House program for another 90 days. From there, we worked to get them into a local recovery residence where they had been for months, and then unfortunately they had relapsed. And we've expanded our public inebriate programs as we're re-envisioning them as engagement beds. That recovery residence called us up, said, hey, can you provide a safe bed for this individual until we're ready to accept them back when the substance is out of their system? We brought them into that engagement bed, and the recovery residents a few days later took them back into their home. So the idea is building out this continuum of care, whether it's our high-intensity units that are designed for 2-3 weeks, not limiting to 2 or 3 weeks, can be longer. Our lower levels of inpatient or residential care and these engagement beds to fill the gaps. That's what we've been working on in the Rutland area. And we are a provider for the entire state too. So it's not simply limited to Rutland individuals.
Can I ask a question? You talked about your capacity at, I'm going to ask a couple questions actually about Serenity House being 34 beds and what's your usual occupancy there? Usually 100% occupied or?
No,
Okay.
we've never been, I shouldn't say we've never been 100% occupied. We have been 100% occupied, but when we reach that point, it's usually for a day or two, and then there's a regression toward the mean. We see often low 20s. We tend to operate in the 65% utilization rate. That's pre-COVID and post-COVID.
Okay.
During COVID, we were about 55%.
Okay. Thank you. The reason we always ask this question is because people are always talking about the lack of access to residential treatment. And what about your step down places, the McGee House and Grace House? I think yesterday the deputy commissioner said Grace House usually runs around 67% or so, the average, and actually McGee House she had said was at 75% in the data she was reporting from.
I believe that was from last week's data.
Last week's
I
data.
think we're trending closer to 80% on average. It's those, particularly Grace House, it's not uncommon that we might be at 12 individuals out of 12 beds. McGee House being 16 beds, we tend to see a natural stay at about 12 to 14.
And then what kind of work do you do with the mental health agencies? So, whether it's Rutland Mental Health or CSAC or, when you were talking about people who had significant mental health issues that you might not be able to address where you are.
So we interact with them in a few different ways. When I'm referring to the public inebriate beds, when we do see a mental health crisis, we enlist the services of Rutland Regional Medical Center for an evaluation. And they have a section of their emergency department specifically designed for mental health intervention. At our high intensity residential and low intensity residential, we are providing aftercare plan and services to all of our individuals. We're consistently sending people to designated agencies around the state or other preferred providers. When there is a mental health emergency at one of our facilities, we're calling crisis. And usually there's an embedded crisis worker that might come out with or without law enforcement, or they might suggest, hey, can you transport this person to the hospital for evaluations? We're reaching out to them because that is beyond our capacity, and we've worked very well with that.
Thank you. And then lastly, and I think you're probably going to get to this, is so I've been made aware of the use of the term medical necessity and the need to kind of take a look at that, particularly in the low intensity definition, because it has a very specific meaning in Medicaid that probably doesn't completely apply to low intensity.
It does not. So I would encourage a definition be introduced into the language of this bill that might utilize medical necessity as described by the American Society of Addiction Medicine. That is the gold standard for the continuum of care and building systems and what each level of care should look like. And when we discuss medical necessity, historically, medical necessity has been prohibitive to longer lengths of stay. When we were fee for service and we were paid a daily rate and we had to get pre-authorized upon admission and pre-authorized for continued stay, we'd have to go by Interqual and McKesson guidelines, and medical necessity stopped really when the individual was done with their withdrawal process. 5 days, 7 days, and then medical necessity was done. Whereas we include more of the clinical component in both of our levels of care, that clinical component might require longer lengths of stay. With our low intensity units, there is no medical care needed. This is a clinically managed program, and I guess I would caution the language of medical necessity because Medicaid might, or other insurance providers might decide that there is no medical necessity for those lower levels of care. And we're seeing really good outcomes with our folks who are staying 60, 90 days.
So you say in your comments that you would work on a definition. That would be helpful.
Yes.
Because you probably shouldn't leave that up to us. And, looking at the internet and as I'm doing now at looking at the association's website and making sure that we, do what is needed,
Absolutely. I'll be working with AHS and BDH and DSU.
Okay, we'll need that next week. Yeah, go ahead, Representative Bishop.
Following up on the question or discussion of occupancy, and I think that there would be surprise with the general public if we talked about the 60 to 65% and 80%, depending on the level of intensity. So I'm not sure where my question is in here, other than there seems to be a disconnect of understanding. Is it that we as a state are struggling to get people to take advantage of the existing services versus I find it hard to believe, and maybe I'm buying into that public narrative, that this is the extent of the need for the services across the state in light of what we're viewing as a pretty deep crisis of substance use.
The figures that I'm familiar with indicate that 3% of folks who need treatment go and get treatment. 3% of folks who need treatment do not go and get treatment. And 94% of folks who need treatment do not know they need treatment and do not get treatment. Right. Now, that doesn't mean everyone needs treatment at our highest levels of care. This could be outpatient levels of care. But what are the barriers for these individuals in going to treatment? And what we're finding is that oftentimes motivation plays a role in this. Our no-show rate is higher than what I would like. When it comes to transportation, we hear a lot of that, but if it really comes down to it, we'll go get the person. We work very well with Medicaid transportation for a lot of our folks, and that's been a wonderful transport service. And I think something that may be fueling the public narrative is perhaps what they're seeing presented and what may be happening behind the scenes might not be the same, right? For example, we've had some individuals call us, gee, I don't really want to go, but my probation officer or my spouse or DCFSA and I have to go. And, we'll do the screening with them to make sure they meet our level of care. And then they'll turn around and say, well, I can't get it, right? How do we work on motivating those folks to want to come in? And so we've, and fortunately and unfortunately, confidentiality laws prohibit us from reaching out to those individuals to say, hey, here's what's really happening. So there's a combination of things that are preventing folks from going to treatment, and motivation is a key factor for that.
What level, if I can ask a follow-up, what level of referral or interaction is for justice-involved individuals, and is there them coming to Serenity House or to Grace or McGee, can it be, or is it sometimes a required part of their interactions with, due to a probation officer's demand or request? Can you share this a little bit more about that?
So when individuals are mandated to treatment, if you will, it's not typically a specific program, but it may be that they have to go seek substance use treatment services. We do work well with our DOC counterparts and getting folks in and transitioning them out. The figure that is known to us, so individuals coming in, disclosing they're a part of the Department of Corrections or Department of Corrections reaching out and making a direct referral, 25% of our population. Anecdotally, I would say that that figure is probably closer to 50% with the folks that we're not aware of, because we do learn after the fact that like someone had a probation officer and they never disclosed that to us. And, you know, they came to us on their own accord. And so their probation officer might not have known that they were coming to us for those.
Simple.
Just to piggyback off of that too, and I think we use like motivation as a broad term here, but I'm sure from your professional experience, you know this too, but like with the handful of folks in my life, maybe like 3 or 4 who should qualify for treatment, like costs, their understanding of what the cost would be personally was a huge factor. Childcare access, like that they would have to leave their kid behind to kind of fend, like that they didn't have an option there. And like leaving work, even though of course you're dealing with substance use, you're not performing at your best, but still getting that paycheck is like critical. So I think, yeah, the motivation, there's so many underlying pieces to that too, but
Yes.
yeah.
Childcare, work, absolutely.
Yeah.
Relationships that prevent folks
Absolutely.
from seeking
Yeah.
treatment, for sure. Now, I believe it was yesterday, there was question in this committee about the perception that the DOJ has on lengths of stay. Earlier this week, I met with Judge Griffin and we talked about treatment court and how they interact with our system, and did some education work on the fact that it's not simply a 14-day program. We keep people for longer, as long as indicated by the American Society of Addiction Medicine. So we are doing that work with the courts, and I'd like to do more of it. I'd like to do a little bit of a tour through the state and the court system. So
That would be great. When you mentioned tour, and I realize it's a sensitive space, but this is an area that we deal with in this committee quite a lot. So would you be open to our committee visiting?
absolutely.
Okay.
That'd be
I would
great.
like to. Thank you. I have a question about, you said that you do utilize Marble Valley Correctional Facility. Do you have any data on like, what percentage of folks that kind of come through your door that you end up having to, really work with the correctional facility about because of your safety concerns?
I do. I don't have that figure with me.
Okay, that would be great if you would be willing to forward that to us. And I mean, I see overall that you seem to be supportive of the repeal language. Stating that essentially feel like we should have as many options available as possible.
Mhm.
I think that there's probably a preference for community-based options. And I'm just am wondering, it feels like we don't have equitable systems in the state, so what that might repeal of the language might be perfectly fine if we're in Newport or, maybe we're in proximity to your services. And I'm not sure if it's the same in other parts of the state. And so we are going to have Department of Corrections here, hopefully with some data about how often their facilities are used for this purpose. And I think one of the take homes is really in order to make this work with the resources that the health department is putting out for this is that you have to be co-located with some other 24-hour program. I mean, that's the essential takeaway from that. And I appreciate that's sort of very concrete. To what extent because this really seems like a crossover service, and need between the health department and the Department of Mental Health. And it seems like only for the public inebriate program that only resources come from the health department, it's seeming. And then there are some other resources, for co-occurring situations or that helps to fund other aspects of the service system. And I guess I should have asked this of Stacy as well, but to what extent do these departments interact in terms of systems development that's necessary, in this space?
That is
Your
a
opinion.
great question. I might have to defer to the departments on.
Yeah, okay, well, I
that.
don't want to ask them how they interact because I know what answer I'm going to get for that. I'm just curious what the community's perception is about that.
So in terms of co-locating, I think where our success is, we're able to separate our residential program with our public inebriate program. In thinking of your question and combining it with more acute mental health services, it may be a fair statement to say that there's a lot of demand of our mental health services in the state. And if it's a matter of a program like mine, making sure there's a safe bed for someone who's intoxicated to keep open a bed for a more acute mental health scenario. I think that's where, we do want to see options that may be more substance use specific, because I can use those beds for folks who are intoxicated or folks who are being removed from a recovery residence or folks who are trying to get to Serenity House and, they've got a day-long wait and they're in dire straits. So that's my only thought around that question.
Thank you. And Kelsey, I'm sorry, I referred to you by the wrong name. What interaction do you see? I mean, so like when I'm thinking about what you've built out in Front Porch, I mean, that's clearly something that's a integrated program I'm just wondering your experiences in these departments working together in order to facilitate an integrated program or service in the community.
Yeah, so I would say that, we built it intentionally from us. We work much more closely with DMH. That's our close partner, and saying, I would say that there's probably some ability to improve the connection between the two. And one thing I would say is that, we're headed towards CCBHC, and that was a big part of the intentionality, which is co-occurring work. And so having them come together and work more closely together, and maybe it's just like you said, going back to those original level principles, they're so similar, but there are specialty needs to the point that was just made, saying, how do we figure this out? But it would be nice to see a little more collaboration and connection there in terms of developing programming, which I think some of the work they're doing seems like they're moving towards that.
Yeah.
So hopefully we can continue on that and see a little more intentionality between the two. And one thing I get that they're under the Department of Health and saying the prevention work makes sense, but DMH does so much service provision, and then the DSU stuff is like the service provision stuff, like Pit Bed seems to have a closer connection. So I know that's a discussion point for HS, saying like where to fit, but I think a little closer connection, given where we're headed, would be helpful to the process.
Yeah, thank you. Have you reached the end of your comments, Chad?
I believe so.
Okay, already. So just to close the loop and make sure that we can get from you a recommendation around the substitute language for medical necessity. And are you recommending, I wasn't quite sure, are you recommending that it be changed in both the high intensity and low intensity, or just the low intensity?
In both
In
locations.
both, okay,
The high intensity does include the medical component,
yes.
but after about a week, when withdrawal management is complete and that physical dependency has been addressed, there's still some high intensity work clinically that needs to be done.
Okay,
And so we don't want to stop things short.
okay. All right, thank you.
Thank you.
So appreciate that work. Any final questions for Mr. Vijay? Thank you so much for being here.
Thank you.
Thank you so much. Appreciate it. Okay. That was really helpful testimony this morning. Folks, you have a little bit of extra time for lunch. We have at 1:00, we have H293, an act relating to health equity data reporting and registry disclosure requirements. That's from the Department of Health. That's essentially sort of the Department of Health letting us know why it is that they need this sort of miscellaneous health department bill. It's a cleanup bill that